the Bansi Sabu show. I call this as a Bansi Sabu show. So it's like, welcome to everybody. The topic allocated to me is 25 years of Acarbose in India. And with me, I have a colleague of mine who is now in Ohio, but was a resident with me at KM Hospital when I was doing DM endocrine. When we did a phase 3 registration trial for Acarbose in India. It's the first of its kind trial we did at the KM Hospital. So I'm reminded of that. And that time we used to have all manual records. Everything was physical. Consent also was very physical. There were only 3 translations. And that's the time we did this work. Acarbose session is sponsored by Bayer Zydus, and I have a conflict of interest with them. Though I'm not paid for this talk, but I do have a conflict of interest with them. And I have been associated with them for the last 25 years. So, it's an agent with evidence base in Indian and Chinese population. If you go to China, the most prescribed drug in any category is not a multivitamin. Like in India, it is a multivitamin or a insulin. I don't want to take trade names here. In China, the most frequently used drug in any category of medicine is Acarbose. I think after Chinese herbal medicine, they take Acarbose. Everybody takes Acarbose because they all have starch, and Indians also eat starch. So in 97, it was approved for type 2 diabetes. It was in 99, the DCGI then approved it for type 1 diabetes as an adjuvant to insulin. Because a lot of our type 1 diabetics actually gain weight. And this starch blocker, Acarbose, actually was approved in 99 by DCGI. And it was the first drug to be approved in pre-diabetes in India for IGT in 2006. Because the Bayer German team actually did research trials for them. So it was approved for type 2 diabetes in 97, 99, type 1 diabetes, 2006 IGT. And it also has a category B approval for pregnancy and diabetes. In fact, in Singapore diabetes guidelines, if you see its lifestyle, then it's Acarbose, then is metformin, then is insulin for GDM. So it is very safe to be used in pregnancy. And across the world, Acarbose was approved in 1990. It's approved in 117 countries, including US FDA. And is of course a very widely used alpha-glucosidase inhibitor, but unfortunately we have been using too much of Oglibose. This is the only, it's actually a biotechnology product. It is made through a fermenter. So it's technologically very expensive to make. So we know that how is a glucosidase inhibitor developed? Professor Tripathi is going to tell you about another molecule and he'll tell you a basic science. But we know that whatever we eat carbs, we eat fat. And we know that our metabolic control is all in the diet. And it's deeply ingrained in nutritional behavior. And we don't understand our diet very well. And which is why we get all this long-term type 2 diabetes is not under control. And we need to manipulate intestinal digestion and absorption. And therefore, enzyme inhibitors like glycoside hydrolysis in the intestine showed 50% reduction in postprandial glucose levels. Our problem is prandial glucose. Whatever you eat, whether it's breakfast, lunch or dinner, our prandial glucose goes up and it's all our glycoside hydrolysis. And therefore, it has a very unique mechanism of action. Particularly, it is very important because Indians, we eat a lot of carb-rich diet. And alpha-glycosidase inhibition leads to delayed intestinal carbohydrate absorption. That's the first thing. It lowers the post-meal glucose. It reduces the need of insulin on the beta cells. It improves insulin sensitivity. And we also know that when carbohydrates are pushed into the lower intestine, they actually stimulate the K and the L cells to make GLP-1. So it's an inbuilt gliptin. It's the first inbuilt gliptin. And also if it goes further down, it causes symbiosis or gut microbiome. So Acarbose is very unique agent because it not only improves the prandial glucose and insulin sensitivity, but also enhances physiological GLP-1 secretion and gut microbiota. So that data is very clear cut. How is it different from others like Voglibose and Miglitol? Because those are the other two. Because Acarbose is involved in the degradation of disaccharides, oligosaccharides and polysaccharides. And we all know that the enzymes we have in the intestine are alpha-glucosidase. In the pancreas is alpha amylase. saliva is alpha amylase, and they compete with polysaccharides and oligosaccharides. So if you look at acarbose is the true alpha glucosidase inhibitor because it inhibits various alpha glucosidases in the order of glucoamylase, sucrase, maltase, isomaltase and dextrinase. And they also inhibit salivary, pancreatic amylase. While voglibose data is not available on what enzymes it inhibits, it's not approved in more than 3 countries in the world, and no action on pancreatic and salivary, and it's only a disaccharide agent. And miglitol has a little better data than voglibose because it is inhibiting sucrose, glucoamylase, isomaltase, lactase and trilhase. It's again a disaccharide agent. It has nothing to do with oligosaccharides and polysaccharides, and that's why that little bit of flatulence you get with acarbose is very unique to it, and it has to be taken with the first morsel of food. So there's a big difference between acarbose, voglibose and miglitol, and that's what we need to recognize better. We also know that when you look at structure, the structural uniqueness renders acarbose as the only AGI which allows polysaccharides to enter the large intestine for the gut microbiome. Because acarbose is a bigger molecule. It's a pseudo-tetrasaccharide. While voglibose is a very small pseudodisaccharide and miglitol is smaller. So acarbose is a unique alpha glucosidase inhibitor with a different structure. And it is reducing the prandial glucose with an insulin sparing action. Again suitable for the Indian diabetic patient. And it actually resurrects the first phase of insulin secretion. We know in type 2 diabetes the first thing to go, and that's why it was approved in pre-diabetes, was the early phase or the first phase of insulin secretion is resurrected by it. So we have 25 years of Indian clinical evidences of glycemic control with acarbose, metformin in acarbose, GLP-1 response, glucose variability, gut microbiota, and it is one of the early agents. Stop NIDDM trial was the first cardiovascular outcome trial on planet Earth, much before all these CV outcome trials came for all the SGLT2 inhibitors and GLP-1. So glucose control with acarbose is robust. This is a meta-analysis from the Cochrane review of 28 placebo randomized control trials, which clearly show that the A1C droppage is very, very robust. Up to a percentage, the fasting glucose and prandial glucose both are dropped substantially with the area under the curve, and this is more than 17-year-old data. And if you look at the 2013 meta-analysis on Eastern diet, which is our diet, on the Asian population, the A1C reduction with acarbose is 1.54%. And this is a meta-analysis of 46 studies, RCTs again. So clearly it works. It clearly also shows that it reduces the glucose under curve. And this data was again an Indian data which shows that the Gluco-VIP multinational real world outcome study from India with 15,000 plus patients clearly showed that it works on the glycemic control. And Lancet in 2014 published this data, the March study, metformin and acarbose in Chinese initial hypoglycemic treatment, and which clearly showed that newly diagnosed type 2 diabetic patients who have an exaggerated prandial glucose response are very well treated with acarbose. And if you see the newer drugs, for example, DPP-4 inhibitors or SGLT2 inhibitors, head to head, the efficacy of acarbose is at par with both of them. So this is real-time data which I am showing you. And as I told you, acarbose was the first agent on planet Earth to have stopped NIDDM patient in pre-diabetes. And it reduced the development of new diabetes by 25% and increased reversal. It was the first remission drug, and normalized glucose tolerance by 35%. So it was a drug in remission. Also, it's an ideal combination partner. This is the initial phase 3 Indian study of acarbose to metformin. And Dr. Jairam, who used to be a professor at medicine at JJ Hospital, had published this study in JAPI long time back, almost 12 years back, clearly showing that when you combine it, acarbose with metformin, there is a synergistic effect. Compared to that, Voglibose is much more weaker. And that data is available on clinical.gov, and they have not even published that data. And if you look at meta-analysis of alpha glucosidase inhibitors, as it is a perfect second line after metformin, both in terms of A1C reduction and hypoglycemic events. So for all similar A1C reductions, there are differential hypoglycemic risks. And if you see the network meta-analysis of 62 RCTs with more than 32,000 patients, Acarbose efficacy is similar to all OHs. Whether it's the gliptins or the glyphosines, head-to-head data, it's actually having an A1C drop higher than a gliptin or a SGLT2 inhibitor as well. The reason for that is Acarbose has benefits beyond diabetes control. It has impact on GLP-1, it's an inbuilt gliptin, it reduces glycemic variability, it has a modulatory effect on gut microbiota and cardiovascular benefits. So Acarbose enhances GLP-1 secretion because this is a publication from Japan which very clearly shows that when you have Acarbose, it actually allows the various saccharides to go and stimulate the K and the L cells of the intestine to make GLP-1. This is the first data to show that after 60 minutes, area under the curve of GLP-1 goes up because there is unabsorbed carbohydrate in the intestine. And adding Acarbose to glucose levels significantly improved breakfast and prandial peaks on 24-hour CGMs. And Dr. Bansi Sabu is also involved with me in some of these works on CGM profiles. So Acarbose clearly decreases intraday glycemic variability. The time in range comes very, very elegantly when you add Acarbose. You can see the MAGE is 20 milligram lower, the standard deviation is lower, and the overall time in range is better. And glycemic variability, even when you add Acarbose to premixed insulin, which we often use in India, you can see the coefficient of variation, the MAGE, the standard deviation is statistically significant. The biggest advantage of Acarbose today is its impact on gut microbiota. That flatulence, which is a socially unacceptable side effect, which Voglibose doesn't have, actually is beneficial to the heart. You know, a little bit of abdominal gas is good for the heart is what they say. And this is Chinese data, 2 publications in RCT, where you can see they say that you are not rich in how much money you have in your bank, but you are rich in what type of microbiota you have in your intestine. And you can see here very clearly that after Acarbose treatment in a randomized double-blind crossover trial, there is a higher abundance of the genera like Lactobacilli and Dilister and lower the bad bacteria. So there is symbiosis, almost 40% of better bacteria are there. And these microbial alterations, because the carb in the lower intestine, facilitate gut symbiosis. And you get good mycobacteria and bad bacteria are gone. What is the evidence that Acarbose has cardiovascular benefits? Well, the ACE trial, which was the cardiovascular evaluation in IGT, clearly showed it had a 5-point MACE. See, now most of our CV outcome trials are using hospitalization of heart failure as an endpoint and translating it up. While Acarbose showed neutrality on 5-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for unstable angina, and hospitalization for heart failure. And for hospitalization for heart failure, it was statistically significant. So if you just use the ACE study and try to put it like a DAPA-HF, the data is as robust. It's as significant. So really, it had that impact, but they took the 5-point MACE. And you know that after the proactive study, people took off the non-fatal stroke completely. So Acarbose also has data from the Myriad data to show that intervention with Acarbose prevents CV events in diabetic patients. And the real world data published just 4 years back in the Endocrine Society Journal of the US showed if you use Acarbose metformin, the incidence of stroke, atherosclerotic heart disease and myocardial infarction events is significantly less. Hospitalization due to stroke, 33% relative risk reduction. Hospitalization due to atherosclerotic events, 31% relative risk reduction. Hospitalization due to myocardial infarction, 34% relative risk reduction. So this is robust Asian data to show that it reduces that. And if you see the Beijing Community Diabetes Study, 10-year follow-up, Acarbose reduced MI by 50%, all-cause death by 52%. So it is the most widely used agent in China because it has outcome data on myocardial infarction and all-cause death. And you can use it even inpatient. And this is data from the COVID world, from again China, where they use inpatient metformin acarbose. It reduced mortality of COVID patients with type 2 diabetes. This is again right out of the stable from Wuhan. So this data is published from Wuhan. And Dr. Makkar is here still. Whether you see the IDF guidelines, the ACE guidelines, the RSSDI ESI guidelines, all the guidelines recommend AGIs. From India, Japan, Korea, China and Taiwan, because we are the CARB countries. And we know we had done the starch study and we have shown that very clearly. So the key points are, acarbose is a very, very good anti-diabetic agent. As a background therapy, independent of baseline A1C, independent of duration of diabetes, independent of BMI, independent of patient's age. It's a very good geriatric drug. It can be used long term. It need not depend on beta cell. It is useful on insulin resistance and can be used in all comorbidities. Thank you for a patient.